So as we move forward here, I'm Chris Nowak. I run the clinical engineering program for community health systems out of Franklin, Tennessee. We're one of the for-profit health systems in the United States. So we own and operate hospitals, 64 hospitals across the United States, from Palmer, Alaska to Key West, Florida. So pretty cool sites, some of them. Some you don't want to go to, and after September, like Palmer, Alaska, gets a little airy. And even we have to plan accordingly if we're having installs done. So the manufacturers don't typically like to go up to Alaska between, November, December, January, February. It just it's not a good situation up there. But anyway, that's a little bit about CHS. We also own about several hundred freestanding emergency departments, imaging centers, radiology centers, surgical centers. So we have almost 250,000 devices in our inventory. So pretty fun place to be. And we're going through a little bit of a transition these days. So we're in the process of hiring some regional directors to manage some of the regions that we have, and looking forward to the new beginnings for CHS Clinical Engineering. So that's a little bit about me and who employs me. My topic today is strategic sourcing for healthcare technology management. And just like it matters who we hire, it matters who we hire as our business partners. It's so important. It makes all the difference in the world. As I had the opportunity to travel around the country, and some of my other employments, got to look at so many different places, from small community hospitals to university teaching hospitals. And I was always amazed at the way some of the operations ran, that there could be a salesperson that makes a phone call from somewhere, and they want you to send your $60,000 TEE transducer to them for repair. And we do. There's some of us that do that. I, on the other hand, as we go through this presentation today, I'm a little bit more concerned about who I provide that $60,000 transesophageal probe to for repair. And I'll tell you a little story about when I first came to CHS. Oh, I'll tell it now, because since we're talking about transesophageal, it's right on the top of mind. One of my directors, I get to see invoices that come through our strategic business office for approval, and this was for a repair of a TE probe. And it was a vendor I never saw. So I come to these things and I get to see all the vendors that support us. I do like to support the vendors that support, these functions and AMI functions that give back to our career field. But this vendor I never saw before. So the first thing I did was Google Maps. I look up the address that's on the invoice. It's some guy's house in California. And I'm like, what the hell is this? So I called my director and I said to her, hey, how did this happen? Like, I don't know this vendor. And she goes, I think it was a phone call, or he showed up at the door or something like that. They had just so happened to have the broken transducer and gave it to the guy. And so obviously I was upset, and she said, I'll do a little investigation. She investigated. She called me back a short time later, and she said it went to Lennard, the company Lennard. That company's in Canada, Toronto, Canada. So this was a broker working out of his house, sends a $60,000 transesophageal transducer to a company in Canada that I didn't know, but I did call one of my designated TEE person who we send those out to repair for, and they knew the company and said, hey, you know what? They do pretty decent work, but yeah, you shouldn't want your $60,000 transducer to go across the lines of the country for repair. They don't have the FDA in Canada. So so that was a story, and I think that may have even led me to putting together this presentation. So we'll move forward. So we have a little agenda for my slide deck, some of the topics that we'll touch that I think would hopefully help you think about who you partner with. From a vendor perspective, I always like to look at my top 10, top 25 vendors that I'm spending money with. I want to make sure that the value proposition for that cash that we're spending is appropriate. If there's any opportunities to dive deeper into that spend, and are they really being a good business partner with us? Do we have that discussion? Maybe something has changed. Maybe they were acquired by a new PE company or venture capital company or something like that. Needed some more margin or something. So we'll define your goals for your purchasing, your priorities, your total cost of ownership, patient safety, clinical quality, regulatory compliance. So, our programs, I know there's some programs that have earned ISO 1345 or 9000, 9002 certification, EQ 56, if you're following that. I like to follow some type of a quality management program. So I typically, not that every vendor has to have some type of ISO, but I typically like to see if they do, or I start asking questions, what is your quality management program? Because as I always describe is, if I'm using a third-party repair vendor and the stuff hits the fan, and the stuff will hit the fan. There's times I've gotten a package from a business partner, vendor, business partner, one of those icons that have a big meatball on it, and it was a brown box, one of the most horrible packaging. Like the stuff inside was totally trashed. And so, even they make mistakes, right? So we have to manage all of our business partners that we use. So that top 10, top 25 vendors with spend, use some spend analytics with your EAM. If you can draw that out of your enterprise asset management system, that's going to help you determine some of that. So as I mentioned, strategic business partners, not vendors, because vendors to me translates into transactional business. I don't want to deal with my business partner on a transactional basis. I want to have a long-term relationship with those business partners. Again, if the stuff hits the fan and I turn around, I want to see them behind me, that they're going to make it right. Because all we do is for the patients that are walking through the front door of the hospital, right? Those patients are counting on you and your team to be excellent every day, every single day. They don't want to hopefully not have to cancel a diagnostic or therapeutic procedure. They've already had their neighbor or their loved one drive them there. So now we're impacting, when stuff like that happens, we're impacting not just the patient, we're impacting the loved one that may have brought them there, the physician who was supposed to do the procedure. There's so much impact associated with if we're dealing with a poor provider of parts or services. Always monitor what you're doing and keep on assessing. Develop some goals in the beginning of your process, right? If you don't plan, you plan to fail, or whatever that. So have a plan. And then if you're not meeting your goals or you need to adjust, be prepared to adjust. So scope of services, let's start from the beginning. What type of a program are you running? Are you having a basic biomedical services program? Is imaging, is clinical lab involved in your program? Rad-onc, Biomedical device integration, to what extent? So you start to target those vendors that tailor more toward the type of program that you're running for your employer. Then you look at these areas. Do you want to make or buy? Do you have the skill set on your team to make the repair, make the service with your own hands, or do you have to buy the service? We make those decisions on a daily basis. Hopefully, you're making those decisions on a daily basis. You know, the vendors, manufacturers, from a, you know, putting more hooks in our technology to make it more difficult to service the gear. And you really have to be cognizant about that when you're buying devices, right? So have a seat at the table during the capital equipment process. We're going to have a discussion on right to repair here in a couple of hours. Hope you come to that as well. And really having a seat at the acquisition table, the buying table, is where that should be addressed today. You know, if we're waiting for the government to save us, the government isn't going to save us. So, so get to that purchasing or that buying table. Service delivery plans. Oops. Everybody know what a service delivery plan is? You know, I have a service delivery plan for all of my devices in the inventory, right? So that's the discussion that you have with your department head. And, you know, let's say it's the ICU. So they're heavily involved in patient monitoring. You know, our team, our in team is your team to provide that service. We're going to do it all in-house, even down to the biomedical device integration. So have a service delivery plan, write it down, make sure your department head for that department knows the service delivery plan, just like in imaging. Make sure they know, hey, you know, if you're going to outsource the MRI service to the manufacturer or a third party, we all agree to it. The good, the good, the bad, the evil associated with that strategy, and what the expectations are with that strategy. And organizational implications, group purchasing organizations. We are an owner of HPG, Health Trust Performance Group, Premier, Vizient. You know, there's so many GPOs out there that your organization might belong to. Look into it to see if they have any relationships on the service side. You know, my experience is that the GPOs have somewhat of a poor track record looking out for us, right, on the service side. Even when they negotiate capital contracts. So luckily with HPG, I'm on the radiology advisory board for HPG. So I get to have a seat at the table for those vendors that we're going to select for any of the imaging products that HPG owners or clients will buy. So if there is, though, HPG does have a few contracts that related to service, and if we run that volume through HPG, obviously we benefit at the end of the year through kickbacks. They're not kickbacks, but they're admin fees and things like that. But just be very cognizant that that's part of the solution too. You can't ignore who your GPO is. Okay, as I said, put some goals together. What's your big, hairy, audacious goal? What do you want to accomplish by vendor management, by strategically sourcing your parts and services? So if your only goal is to save money and you're being sold like this, you're not being very strategic, right? You just want cheap. If you just want cheap, then this probably isn't the presentation for you because I don't buy cheap. And when I talk to my business partners, I want them to win, right? I want them to win, but we have to win as well. We have to have a common goal. They have to pay their electric bills. They have to pay their staff. You know, one of the things I do with my vendors now, I have this opportunity is I get to go visit, right? I want to go visit the people that I'm going to partner with. And one of the things that I do, you know, they bring you into the nice room, right? And they might have some refreshments around, or and but one of the things after they give me their, you know, this is the company and how great and everything like that. One of the things I want to do, I want to go out to where they're servicing my endoscopes or whatever patient monitoring, or my telemetry transmit. I go out. I want to walk among their staff, and I want to talk to the staff. I want to ask them, hey, how's it going? How do you like what you do? You know, I want to see if they hate their job, right? That's the first thing I look for, is if they're so disgruntled about their job and where they work. I don't want them working on my $60,000 transesophageal or my $45,000 endoscope, or, you know, I don't want them working on that. That's scary stuff, right? I want them to come to work where they're, you know, they're well taken care of, they're paid decently, they have a good environment to work in. So yeah, I get that opportunity. I'm very lucky. If you have that opportunity, you should take that opportunity. Some of the larger business partners will help you out with that kind of travel to come visit. They're all more than happy to provide that. Some of the smaller ones that I deal with, obviously, the good thing is I have hospitals around the country, so I could usually work it into a hospital visit. But yeah, if your salesperson is coming in and saying, hey, yeah, I'm cheap, I'm cheap, I'm cheap, I'm starting to turn off that. That's not the person for me. Priorities. I love this one. For me, my priority is not to have my employer's name on the 6 o'clock evening news, because some part that we bought or some service that we bought from a third party caused the machine to fall on top of the patient during the nuclear scan or something like that, right? So I put that up there because that's a driving factor. That's a big driving factor for me. I want to look out for my employer and make sure that we're doing the right thing and not being cheap. So, you know, not being cheap, but, you know, when I talk about my employer, I make sure that my employer has a dashboard on a monthly basis. They see the top 10 vendor spend. You know, I typically show them a top 10 vendor spend, and this is the spend with these vendors. This is why we spend this kind of money with these vendors. And that's a monthly dashboard. We use a Tableau. We take all of our data and put it into a nice Tableau graphical image, because you don't want to put a bunch of words in front of your leadership, right? They're usually very busy. If you put a nice picture in front of them, they look at a picture, they can see exactly how well you and your team are doing from a fiscal perspective. And then there's regulatory analytics that I put in that report as well. So spend analytics. Where are you gathering your spend data from? The beautiful thing, our CMMS, Enterprise Asset Management Software, the technicians order through the EAM software. That has an integration, API integration to my financials. And we use Oracle ERP. So that has an integration into our financials. There's an intercept to buyers when a tech puts in a request for a part or a service. There are buyers that intercept that, and they have the opportunity to source it, right? So let's say we have Philips patient monitoring, and we're buying parts for my 10-year-old Philips monitoring system. Well, I typically don't buy those from Philips, right? I typically buy them from a third party. So the vendor or the buyer gets to intercept that and switch it. If the technician had it for Philips, the buyer will switch it. It then sends through Oracle. We get the PO back. The buyer reviews it, sends it to it's all automatic process. It's just hitting buttons in our system and sends it to the tech. So the tech knows the part's been ordered. The tech made a request when that first request was made. Do I need it overnight? Can I get it ground? And all that information is relayed back to the technician. But the beauty of that is I get to gather all my spend data. I can see to the penny. So in that monthly report, or if my leadership, imaging leadership wants to know how much we're spending on all of our Canon CT, I can tell them by model what the cost of ownership is on an annual basis for a Prime 160 or a Prime 80. So it's good data. Now, if you have to go to your finance group, that could be a little bit more difficult. Unless you've already worked with your finance team and the POs that you generate, maybe it has a B in front of it for biomed, or, try to designate, because if you're all piled into the general fund, it's very, very difficult for them to, the first time when I arrived at CHS, I asked about how much are we spending. They had no idea. They had no idea. They sent me 87,000 line items of spend. I'm not going to go through 87,000 line items. You're out of your mind. I can't do that. I don't have time to do that. So, that's a big deal. So if you have the opportunity to work with your finance team and identify expenses just for your program, that'd be great. What role does your EAM? I talked a little bit about that. What we do, hopefully your EAM might have that same opportunity. The API integration it's a great thing, man. It really helps you identify your spend. So what's your categories? Make sure you break it down into categories. Your traditional bio, imaging, glassware, non-glassware. What are you spending in the clinical laboratory area? Because that's how I report it out. Okay, that's how I'm reporting it out. Because there's different leadership that wants to see that stuff. Information technology, again, remember I said we're doing biomedical device integration. So you want to see how much you're spending. Maybe if you're using a small form factor computer that's connected to your anesthesia machine and you're pulling that data out serially and sending it to the EMR, if there's maintenance associated with those devices. So you're going to have some spend associated with that. And then obviously all of your consumables. If your department's buying consumables, great. If it's not, so be it. Selecting your business partners. Be strategically minded and make sure your business partner is strategically minded. I do, and I spoke about this, I don't like when they keep coming into me and trying to sell me on price. It's not a price thing. It's quality. It's, when I turn around, when the stuff hits the fan, are they going to be there? Are they going to honor their warranties? So that's a big deal. Can you visit the facility? If you do visit the facility, meet with leadership is great, but the real important stuff is the opportunity to speak to their employees, even the shipping department. That could be, my buyers would tell me from time to time, like they're checking up on a shipment, and like that guy in the shipping department is just a jerk, and we drop those business partners. We don't want to, no, we're all in this together. We're trying to provide for our patients that we serve. So, we got to get rid of them. Getting to the point where you don't feel that you need to keep an eye on them, right? That's not a big, right? You don't want to have that feeling that, hey, am I getting the best value? And that's what I don't want for my technicians, right? I want to take that all away. I hate when they sit on the phone and they're trying to find a part, or they're trying to find the cheapest price. I don't want that. We've already done that for you. There's no reason for you to jump on a telephone or be emailing somebody and trying to source parts and services. I want that. I want all of that time to be saved so that we can do more imaging stuff. We can work on more CTs or MRs, and I can reduce or drop those contracts associated with that stuff. Lab equipment's a big deal. I want to work on the automated line. You know, it's a pretty simple system for pulling the test tubes off the automated line. And, you know, service contracts on just that stupid line could be almost as $100,000 just on that line, not the chemistry analyzer or anything like that, or the hematology analyzer. It's just that stupid line. It's almost $100,000. So those gates that pull those, they're very simple devices and they're very easy to repair. I remember it kind of happened by mistake the first time we started doing that. There was a gate that was underneath, and our line went down. My tech went upstairs to try and help the lab folks. And as he was looking around, Gordon found this spare gate that was hanging around. Put the spare gate in, everything worked fine. Took the one downstairs, took it apart, and found out it was really just like dirty brushes, and you know, it was a pretty simple repair. And then later that day, when the lab slowed down, he put it in, tested it. So then we dropped that $85,000 service agreement on that line. So great opportunities to provide that value proposition to your employee and let them know about it, right? So, you know, a lot of this stuff is surrounding that EAM, that CMMS data, right? You got to give that to you got to put that in front of your administrators. They got to understand what you and your team, the value that you and your team provide to that institution. And I said this in my leadership summit. You know, what I'm trying to do is I'm trying to weave a fabric into my institution that makes it so hard for them to look at a third-party organization to come in and do biomed service for our patients. I want them to make sure they're satisfied. I want them to see we're doing all of this work, like the biomedical device integration. Not every third party does biomedical device integration. And if they do, they're going to charge you a lot of money to do that. Or cybersecurity, right? How many people are involved in their cybersecurity strategy? I sit side by side with my cyber team as we look at medical devices. We've purchased the IoT, IOMT software so that what happens is, anybody know what the IoT, like a simile or order, you know? Yep. Yeah. So we have an API integration into our EAM from that. So when the device, because before that, I was counting on my team, because I'm all into IT, and every device that's on the network, I want my MAC address, I want my IP address, I want my operating system, I want all that data in my enterprise asset management software. But I had to count on them, right? My initial strategy was, well, when you're doing the PM, right? When you're doing the PM, you'll go into the software and get all that information and put it into our CMMS. Well, it never happened exactly. Or they fat fingered in. Incorrect. Or they fat fingered in and put mistakes in there. So with this tool and the API integration, once a serial number is matched, we have a system administrator for the software. Once a serial number is matched, it says, hey, you want me to pull down that operating system, MAC address, IP, any kind of demographics about that device that we can pull down, we pull down into our enterprise asset management software. And IT uses ServiceNow. A lot of your products, your EAM products, have a bidirectional integration with ServiceNow. So now my IT team has total visibility to the medical devices. You know, as you know, medical devices, IT didn't want anything to do with it, right? All they knew was there's a device connected to an IP address. They had no idea what the device was. Well, now it's very simple. Now they have full access. Oh, it's the CT scanner in Laredo, Texas. So it's instantaneous. It really is. So some pretty good stuff from an integration perspective. Let's see. Are they investing in your career field? And that comes back to the point about these meetings, why I come to these meetings and I see these vendors that are spending the money to send us here. Number one, to send us here so we don't have to pay an admission fee. I do try to support those folks, right? If they're supporting the education of my staff, then I want to support them. It takes money to do this. It takes money to fly folks down here to Baltimore to put a booth up and kind of be there to talk to you all about their product. So I look for that. Are they investing in, do they have the ISO 1345 or 9000? What does their quality management system look like? And they share their data with you. All right. So again, this is all part of the relationship process, the moving forward. Yes, sir. And questions, please stop me.
Do you have written into your quality management system the audit process and bringing their information in as a business partner? In other words, if they have a quality management system, is that linked in to the information you're holding on?
Other than getting it electronically, like they'll send us a document. That's the only, we do not have any, and that's a great, Bob, that's a great perspective, because I sometimes talk to like like Mindray is our patient monitoring vendor. And, you know, we talk about service, right? I worked for a manufacturer at one point in my career, and we have an MDR, a medical device record, right? So from the time that device starts its manufacturing process, there is an MDR generated, a medical device record. So all the circuit boards that are put into that device, the end-tidal CO2 product, or whatever's put into that device, the manufacturer has a medical device record. And I'm very cognizant of that. So I have talked to some of my vendors and said, hey, look, I will share my service information on the products that we have purchased from you to ensure the integrity of your medical device record. Now, most of them, you know, say, nah, you know, that's okay. You know, Steris, I was going down the route with Steris. But you know, I'm very open to do that. I'm very open to do that. So, but, you know, typically what we will get is the field service report or the depot repair report electronically, and that gets attached to the work order that was open when that device went out for repair. Good question. Any other questions? Okay, so now you have this program set up. It's humming along. Your staff seems to be using it properly, or are they? So you got to set up a process to monitor. Make sure that there's no leakage. What do I mean by leakage? Excess spending, or, you know, yeah, they're going out shopping. They love this expression. Don't go using Joe shit the rag man. So we want to use our vendors. We don't want to start leaking out, hey, you know, but I'm saving, you know, 50 cents. I had one of my team members come back from a CMIA meeting. And again, it was another expensive ultrasound transducer. And we needed one, you know, wanted to buy one from this vendor. And I never heard of this vendor again. And I looked, it's a house. And I said, you know, we can't do that, right? Because I don't know where that transducer came from. It's a very expensive transducer. And yes, it's a great price. Is it stolen? If it needs service and we send it back and that serial number, you know, the manufacturer puts that serial number in, and guess what? It had been reported stolen. Yeah, I can't, I don't want them on the 6 o'clock news. And, you know, so that's a big deal to me. I did have a technician in Corona, California, had a ERCP scope, expensive scope. And thank goodness we had video cameras on the loading dock and him loading it into his car because somebody saw it on eBay, or the hospital he was trying to sell it to called us. And it was a brand new ERCP scope. So it's crazy. But stuff like that happens. You know, but he went out to lunch, came back, and the police were there. But that's crazy. Jeopardized his career. Yes.
Not going with the chief, right?
Yes.
But in healthcare, we're always under the pressure to save money. So how are you handling?
I love that. I love that question. So the question was, I keep on saying, I don't buy cheap, I don't buy cheap. But the pressure that we're all under is to save our employer money, right? I look for the most cost effective. Now, what does that mean? I really don't look. Now, sometimes cheap is the best product out there. But you want to make sure that they have all these other things in process, like the quality management system. You want to make sure that they're going to be there standing behind you. So my employer, obviously, they're focused on running a healthcare business, but they're not looking over my shoulder saying, "Oh, Chris, you could have saved 50 cents over here if you went to that vendor." They're not doing that. So we get to control that. Me and my leadership team get to control that. So you have to make sure you're buying a value-driven proposition from your business partner. And to that point earlier where I said, you don't want to keep on looking over your shoulder. If you've got to keep looking over their shoulder, you've got the wrong partner. You've got the wrong. I expect when I go into that negotiation, and I've been walking around the show here because I am out shopping, and I've been, and I said, look, I expect them to have competitive pricing. I do. That's my first inclination is when I come to you, I'm expecting competitive. I didn't say cheapest. I said competitive pricing. James.
A specific example, I'm just curious of your thoughts on that. So you've gone through this process and you've selected your partner vendor. You've signed the T's and C's and everything's, you're going to live happily ever after. What you notice is a trend with this particular vendor where every instance or every touch with them, they seem to find some reason to move out of the scope of your T's and C's and give you an extra charge.
Yep.
How do you engage that vendor with a reassessment?
Yeah, it's kind of like a marriage or a relationship. You've got to be able to talk. If you can't talk to your vendor, then that's a problem.
One or two incidences they're explainable. Several starts to become a trend.
Correct.
It's now becoming noticeable.
Correct. And what's your out clause look like in your relationship?
It's ambiguous.
Yeah.
The out clause is a upheaval of technology that will take several years and several zeros behind the dollar.
Oh, wow. So you're talking about from a manufacturer then? Yeah.
Patient monitoring.
Yeah, that's a little bit more difficult to manage. It has to do with that upfront process of seating at the table and getting a long-term relationship. So I negotiated a very large multi-vendor imaging relationship with a vendor, and I had some of the big ones, a Meatball and some of the other Dutch ones and stuff like that. And one of the things I wanted in there was training and education because my staff, I really wanted to transition hard into doing imaging. And, I can hire imaging folks, but you get baggage sometimes with that, right? So I like to self-build my team. Yeah, I do. I like to do that, especially from a biomed perspective, because the biomed tech tends to be very resourceful, and if you're hiring the right way, they really same thing with networking, clinical lab, all of that. I like to build it from that, but I've hired folks right from Varian, and but one of those conversations I have with them is when they are in the hiring process, understand I know imaging because I was trained at RSTI on CT. I did CT repair as a young biomed, and you're not always busy doing CT. But I was a biomed, and I worked on CT, and when I wasn't working on CT, I was fixing patient monitoring and doing other stuff. So I make that very clear up front during the hiring process. This is the way it's going to be. And I loved walking, I travel around the country, I walk into my shop, and I see my imaging guy there doing pump PMs, right? Because we're a team. we got to build a team. So I kind of got off track of your, but you know, from a manufacturer perspective, you really got to start at the purchase. And the reason why I went down that negotiating that large contract, all of those terms were spelled out in the length of the contract for the term of the contract. So the price wasn't fluctuating. So your CFO, right, hates variation, right? They hate variation. So the best kind of contract to negotiate is one where over the life of the contract, you're fairly flat. You can lock in some costs. Now, you know, maybe you're spending a few cents extra for that kind of comfort, right? And take that variability out for your CFOs. So,
Yeah, and I think one of the things like you talked about, someone sending out a TEE probe to someone who wasn't even a vendor. They
Joe
just
shit the
steal it.
rag man.
Yeah, they just steal it. One of the things we've really pushed with our teams is, first of all, if they're not in our system, you don't meet with them. Because they show up, they want to bring candy, talk to you. They can come meet with other executives, but they don't meet with you, and no one takes equipment because they stop by. You know, and as I know you do it too, when you negotiate some of these third-party partner agreements, everything might not be the best price out there, but you're getting that volume discount on everything, and you're getting that quality system, and you're getting the documentation you need as opposed to using, you know, Joe Schmo. And
Yep.
you may not get even a worker. You might just get the shipping label.
Yeah,
And that's all you got. It's fixed.
yeah. Yeah, everybody hear Brian? Yeah. Yeah, I mean, that's spot on, right? You know, I'm taking that responsibility out of their hands so they can, I want them to do more work on, you know, it's what I say about nursing and biomed, right? Nurses and rad techs and lab techs, they do patient care. I do not want them to do equipment care. I don't want them in my world. If they have to come into my world, I got a problem. My program's not right. You know, from a compliance perspective, from Joint Commission or CMS, we got to have everything 100% compliant, right? So if a device is on a patient, then we document that a couple of times a month that we made the efforts. If it's lost, we document that we made the effort to find it. As long as you're documenting all of that information, that's great. We're compliant. So they require us to be compliant. If I have to have a nurse or a rad tech or somebody go searching for devices, that's bright. Now, every once in a while we do, and you know, we'll get a Chick-fil-A card or a card from the cafeteria or something like that to try and really make an effort to find like a bladder scanner or something like that. But I really don't want them to do equipment care. That's our job. And you know, we don't use PM stickers, right? Everything has to be 100% compliant. I got a robust enterprise asset management software that the nurse, he can walk over with his WOW, bleep, hits the barcode on the device, up pops the make, model, serial number, when the last PM was done, when the next one's due, looks at the surveyor and says, oh, the next one's due, you know, September 2026. IFU? I don't have that link there. That's a great idea, though. That's a great, because we just had that discussion somewhere else about IFUs. You know, who's responsible? Agree. 100%. So everybody understand where he's going with that? So, you know, one of the, you know, like I'm going through a Joint Commission survey at our Longview, Texas hospital right now. Brian and I were talking before the meeting started, and you know, I'm looking at some of the things, and as soon as I see PE, I'm like, oh boy, PE. So like last night, I got to the hotel room last night, and I saw a couple of PE things, and I asked our quality people, I said, is that, can you give me more detail on that sighting on the PE? Because, you know, we're all in the physical environment for the most part. Got back to me this morning, and it was all maintenance stuff. So they're on our team, but you know, but by the way, RPTs seem to be still a big thing out there. RPTs, fire doors, not closing properly. So just a little heads up for your next Joint Commission survey. Brian asked me, what are you seeing change? Are you seeing them change? We haven't really. I haven't really seen the behavior of the surveyor change at all with regard to this new reorganized.
Rates have changed, but we had a survey in January, and their comment from the surveyor was, because I asked him, like, so how's the survey going to change? He's like, I don't know. He goes, I'm just surveying like I did last year.
Yeah.
Okay.
So it's going to take a couple of years. And Matt Baratic said the same thing. Don't change your MEMP, Now, we did change our MEMP to indicate the change from EC 020401. We now have it a link to PE. So always assess the quality of, you do have to, make sure your team, I tell my team, don't be robots. I don't want you to be a robot. You're a thinking, living, if you see a problem from a vendor that's our partner and it's coming back and the quality, you don't like the quality or something, you got to speak up, right? Don't tolerate that. I wouldn't tolerate it. Why are you tolerating it? Well, I don't want to rock the boat because it's our designated vendor. Okay, it's our designated vendor, but if they're starting to get maybe something changed. Maybe their leadership changed, right? You got to be on the lookout for that stuff when you're choosing vendors. You got, if it's service, if I'm buying service from that vendor and, somebody leaves the organization that was servicing my gear, that's a red flag, right? You should be very cognizant about what's going on because you may need to, in my case, I may need to make a change regionally because I have hospitals all over the place. And if one of their lead service engineers leave, that's a red flag to me. I'm going to continue to assess and monitor that service for who their plan B was to take that person's place. Again, you're always looking at the value of the price you're paying. So make sure if the quality goes down, then you got to have that painful conversation with that vendor and say, hey man, and I always respected them when, and I'm telling these vendors at the show here, look, I don't want to hear that you can do it all, right? I want you to tell me, hey, you know what, Chris, for that stuff, maybe you should consider Joe over here or Bob over there, or, the respect I have for that person pays tremendous dividends for that person, right? Because now I'm going to say, hey, you know what? Anything I got, I'm going to give him anything that they work on. I'm going to make sure, give it all, because sometimes I'll pick two vendors for, blenders or, if they're right. I'm always cognizant about the supply chain, right? Make sure, if you have a problem with one of your vendors, that you do have a plan B in the back wings waiting. And another, I talked about any warning sign. Company sold to venture capital, leadership transition, staff leaving. Have they taken their foot off the gas pedal, right? Because, we're expected to keep our foot on the gas pedal for our team, right? We're rocking and rolling. We're servicing our gear. We want our business partners doing the same thing.
You have a vendor that you're hundreds of millions of dollars into capital. Patient monitoring.
Mm-hmm.
They now take a step back. It's like, oh, we've got your money. Now we've got to move on to our other capital investments. They don't want to do your service like they should be. What's a good strategy to take?
So we just had a vendor like the PM. The PM in their documents say that the PM has to be done. Maybe this was an annual PM, and they came back to us and said, "Hey, we're not doing the PM anymore." And we said, "Well, wait a minute. Your documents say you do an annual PM, and we're buying the service agreement from you. It's under contract, and you go back to the document. You go back to the document. If they're contractually obligated to provide you with that service, then you got to hold their feet to the fire. And then if they don't, you go through the breach process."
say they're not contractually obligated for X, Y, or Z that you need them from. But
Give me an example.
so when we were just doing some stuff with, we were just doing some things with our patient monitoring is Philips. We were doing some software upgrades. And some of the steps were not being met by them, at least in a timely manner. And they wanted to take a step back and they wanted to start charging us more and more. We do have an SCS agreement with them, so we ended up winning, but it ended up pushing back timelines.
Yeah. But I mean, I probably would have handled it the same way. I mean, you gotta either get your attorney involved or, something to try and that's the bad relationship, right? That's when the relationships are going sour, right? So now you have to start thinking more strategically for the next time. I don't know where you're in the life cycle management process of your patient monitoring, but that's when you got to start your senior leadership. Next time we're looking at capital, I was with an organization that I'm a Wi-Fi telemetry guy, right? I don't want any of my telemetry not to be a standards-based product. The vendor that we were designated, right? This is our strategic business partner, didn't have a Wi-Fi product. So some of you might know who I'm talking about. So I went to my leadership and I said, guys, we need to buy a different Wi-Fi because we're buying 1990 technology and we're paying the same money that we could be buying a standards base with a display on it that has alarms locally, on the box. We should be buying, that's the safer route to go for our patients. They let me do it. The next telemetry purchase we made, they let me do it. So, we started buying Wi-Fi from that other vendor. And so it's having that seat at the table. I know it's tough. It just is, it comes down to hopefully your leadership, or if you're the leader, just getting at that seat at the table and making the case. You got to have a day, I'm about to, in another couple of weeks, put together a program for our clinical. So every Monday at 1 o'clock, I'm gonna call with all of the clinical leadership at the corporation of CHS, our CMOs, our CMIOs, physicians, our anesthesia, all of our physicians, our nurses, our CNOs are there. And I'm putting together a demo of a piece of software that I think might be of value clinically for our nurses, reduce workload and alarms and stuff like that. So you got to have that kind of seat at the table to offer solutions. A-Ray, when he got his award yesterday and also at the leadership summit, he's always looking for a problem, right? He's looking for problems to solve for his business or for his employer. And if we're not, then we're not doing our job. That was kind of his thing. Any more questions?
Kind of going back to how you do your analysis and picking, I think I'm loud enough. Okay, I'll go ahead and speak into the microphone. When you're looking at your different options out there for your different vendors or partners, do you ever look at emergency management? One of the things there's two microphones. Yeah. One of the things that I've been heavily involved in is emergency management within healthcare. And how many times have you had a vendor partner that is snowed in and that's their only location that they can do repairs? We had that, I don't know, 7 or 8 years ago up in the Milwaukee area, not only GE, but some of the other providers, that was their only repair site and they couldn't get in. So one of our qualifiers when we're looking at these partners is, where else do you have service centers? And we try to get them into 2 different zones. If your primary and your secondary are next door to each other in Irvine, California, and they have an earthquake, you're probably out of service for a couple weeks. So I don't know how often you put that in, but that is one of the other things I do when I do my contracts to make sure.
So Brian, once again, you brought up a great topic, and one thing I haven't talked about was what to do when the lights go out. So we didn't talk about rentals, so, we're responsible for rentals. So having relationships with those rental companies is a big deal. And like I said, what to do with the light when the lights go out. In your medical equipment management plan, in mine, it speaks to, hey, if we have a COVID epidemic or, some kind of a situation where we have a plane crash or an earthquake and we're going to need equipment, make sure you have relationships with those providers where you have access to equipment or access to service people and make them aware. Like even during COVID, we did have relationships with our service providers because you're never going to be totally free from an outside service provider. We really had good strategic plans on how to get people into my hospitals in Florida. I could recall where, we were trying to get service folks in after a hurricane. Our hospital was pretty close to the water and the basement got flooded, and that's where our cath labs were. So we had the whole plan as soon as the water receded, when they went in, get it back up and running. We had minimal downtime, went pretty well. So document, I'm a document guy, document when you're trying to do PMs or, if you can find it or if it's in use, document. Bob.
From a people management perspective, Chris, when, we're biomeds, we tend to grumble, we get settled in our ways. You have an experienced tech out in the field whose pride is hurt. If you come in and say, no, we've got a better vendor. We've got a vendor we're going to use nationally. We're going to partner with these people. Like, well, I always worked with the OEM directly. I don't see why you're second guessing me. How do you address the potential for, how do you sell the program to the people who are using it? You said make them engaged, but can you go into more detail on that?
Yeah, that's a great question. It's a sign of a good leader, right? You need to be a great leader, you need to have followers. So, I listen to John Maxwell recordings and, I try to learn from those folks and try to make sure my team believes in me, that I do what I say and say what I do. If I tell them something and I don't come through, then I'm going to have some of my shine has lost the luster. It's like, he said he was going to do that, and he forgot all about me. So you got to be on it. When I left UHS, I was there for 10 years, and I reported up through like the number 4 guy in the company, senior vice president, strategic business guy. Like he was awesome. He was an awesome guy. And he said, Chris, I want to take an afternoon and I want you to tell me about all of our facilities and like some of the challenges. So we did that. We sat one afternoon after about an hour and a half of me, and we were only about a third of the way through. Mike stops me, he says, Chris, how the heck do you know about all your staff? Like the detailed information, I knew that this one had a severely handicapped child. So when that person had to ask off a little time off, I understood that. One guy was going through a divorce, and and I'm telling, part of it was telling Mike this because he goes, well, why do you know that? Why do you have that detail? I said, because I have to understand when they're struggling a little bit, I got to have a little bit of lead. Otherwise, they're phenomenal. They're great teammates. But you know what? We all have bumps in the road. So we got to respect. I had this super duper imaging engineer, but Steve worked 8 to 4:30, right? He loved to bowl, and man, was he a bowler! And he wanted to make sure he was at bowling at such and such an hour. So I needed to make sure I understand when Steve was working on something and he didn't stay past 4:30. and he'd let me know, or he'd engage one of the other team members to take over. We briefed them and took over, that I understood that. And I was good with that. And I knew exactly why that was happening. On and on. I could tell the stories about darn near every one of my employees. He just thought that just blew him. And then he said, no, I want you to continue now. And, we went through every freaking hospital from the East Coast to the West Coast. And he just was like, man, I can't believe you knew that much information about each one of your employees. I said,
But as a follow-up, besides charisma, do you have any official processes in? I mean, do you have like an advisory committee? Do you poll people? Do you sample out into the field?
hey, now we had an executive advisory committee. What do I mean by executive? It included biomed techs, it included my regionals, and included me. And we were the ones that were developing policy changes. If we wanted to change a PM schedule, right? Remember, I didn't use stickers. So if we wanted to change a PM schedule, we all looked at that device. We looked at the service history surrounding that device, and we all decided whether or not we wanted to do it. And even though one area of the country might have had a stability for that device, some of our hospitals were located in thunderstorm, Hurricane Alley, and but we wanted to program, if a surveyor went into a California hospital, that looked the same when they walked into a Florida hospital, because I wanted it to get to a point where the surveyor came in and said, it's a UHS program. We know how it goes. So then they don't start digging, right? We don't want them to dig. We had an audit program too. We audited every one of our facilities twice a year. So, a region would audit themselves, and then the second one would be an outside audit, from some other region. So, good question, Bob. Anything else? Well, I think it's lunchtime. I appreciate everybody's time, and I appreciate your attendance, and enjoy the rest of the show. We'll see you at 4 o'clock on Right to Repair.